Many thanks, Professor Ahab, for your kind invitation, and thanks a lot for Nephrology Department, Alexandria University, for your kind invitation, especially Professor Iman Al-Gohari. My presentation today about up-to-date review of antithrombotic therapy for hemodialysis patient with atrial fibrillation. The bottom strip for ECG showed atrial fibrillation with absence of B waves and the irregularity of QRS complex. Atrial fibrillation is present among our dialysis patients, especially with increasing ages and ranges from 4% up to 20%. And in some population like Japanese people, range from 3 to 9%. Atrial fibrillation can lead to thrombus formation in the atria and the atrial appendages and is associated with increased risk of thromboembolic strokes. Therefore, anticoagulation is a cornerstone of its management. Improper atrial contractions lead to thrombus formation, especially in the atrial appendages, which dislodge after and lead to strokes because it delivers to the brain. Patients with atrial fibrillation who have severe chronic kidney disease require dialysis have significant higher incidence of ischemic strokes and bleeding, as shown in the figure. Stroke and the thromboembolic embolism and the bleeding are more evident, more prevalent than in patients with CKD versus patients without CKD. And this was in the Danish cohort study, including around 132,000 patients. There is hemostatic disorders in chronic kidney disease due to uremic toxins and metabolic compounds, which lead to activations of the coagulation axates and fibrinolytic system and the platelet hyperactivity and damage of the endothelium. Also, chronic inflammation, which aggravates the vicious circle of dysfunctional hemostasis. The diagram showed the hemostatic disorders in chronic kidney disease. Direct oral anticoagulants, DOACs, have been proved to have comparative efficacy and the safety profiles as warfarin in reducing the risk of thromboembolic strokes, and they are currently widely used in many patient groups. Our target to prevent strokes, and we are guided by SHAD-PAS score, stroke risk scores, and scores about 1 or more in male, we have to anticoagulate your patient, and score 2 or more, we have to anticoagulate your female patient. On the other hand, we have to mitigate bleeding risk, and we also are guided by HAS bleeding risk score, and the score 3 or more, we have to monitor your patient to avoid risk of bleeding. What about this disadvantages of vitamin K antagonist in CKD patient? In patient with CKD, it's difficult to determine warfarin dosage to maintain the therapeutic range. The inappropriate level of anticoagulation result in suboptimal anticoagulation and increase both the risk of thromboembolic and bleeding complications. Also, there is marvelous vascular calcification due to inhibition of the matrix GLA protein and the vulnerable plaque phenotype. All these factors are incorporated in the pathogenesis of calciphylaxis. Matrix GLA protein is locally produced by vascular smooth muscle cells, which is the potent local inhibitor of the ectopic calcifications. Prolonged usage of warfarin result in abundance of uncarboxylated matrix GLA protein with further vascular calcifications. The acetone vascular calcification increased with the usage of warfarin. Also, warfarin use is associated with progressive coronary calcifications measured with serial intravascular ultrasound. Also, breast arterial calcification increased with the prolonged usage of warfarin. Also, warfarin are incorporated for the faster progression of chronic kidney disease, and this is especially if it's beyond the therapeutic window of INR. Recurrent subclinical bleeding leading to intrarenal tubular system obstructions and necrosis. Also, warfarin can cause acute kidney injury in patients with INR more than 3 due to also glomerular bleeding. As a result, the tubules are occluded, This phenomenon means known by warfarin-related nephropathy. The diagram shows the disadvantages of warfarin, including suppression of the matrix glyprotein, acceleration of vascular calcification, and the consequences of calcifluxes, induction of vulnerable plaque phenotype, subclinical tubular bleeding leading to tubular necrosis, and the faster progression of CKD. On the other hand, the variable doses led to thromboembolic and bleeding, and suboptimal anticoagulation led to increased risk of strokes. This is the site of action of warfarin in the coagulation cascades, but there is main indication of warfarin in which DOACs should not be used, including valvular AF, where DOACs has not been directly evaluated, and also in mechanical prosthetic valve, where DOACs increase the risk of thromboembolic and bleeding complications. In a meta-analysis of 12 cohort studies, including 17,000 patients with AF, warfarin was associated with non-significant reduction of ischemic stroke rates, no effect on the total mortality, and increase in the total bleeding risk, and doubling of the incidence of hemorrhagic strokes in hemodialysis patients. This is a systematic review analysis, meta-analysis, including around 47,000 patients, where ischemic strokes, no difference between the patient using warfarin versus no warfarin, but hemorrhagic strokes and major bleeding increased with the patient using warfarin versus no warfarin. On the other hand, the mortality, there is no any significance to use of the warfarin to reduce the mortality. Another study, systematic review and the meta-analysis about direct oral antiviral versus warfarin in hemodialysis patient. They included the study total patient around 34,000 patients. In their meta-analysis, the outcome were major bleeding, ischemic strokes, systemic embolization, hemorrhagic stroke, gastrointestinal bleeding, and minor bleeding and death. Warfarin could be associated with significant reduction in minor bleeding, systemic embolization, and death compared to DOACs. And they recommend to have further prospective randomized control studies. The site of actions of direct oral anticoagulant in the coagulation axis. We have three direct thrombin. We have the direct thrombin inhibitor, dabigatran, and three inhibitors of factor 10, rivaroxaban, apixaban, and indoxaban. DOACs have better pharmacokinetic profile due to quick onset of action, and therefore no need for bridge therapy with heparin in the first few days of treatment. Also, they have wider therapeutic window, have fewer interaction with other drugs, allowing constant dosing of the drug without INR monitoring or dietary restriction. Dabigatran and rivaroxaban have reducing the plasma concentration of pro-inflammatory markers, including adhesions molecules, cytokines, chemoattractant, chemokines, and tissue necrosis factor. Rivaroxaban also suppress the expression of messenger RNA coding the pro-inflammatory mediators, tumor necrosis factor, and interleukin 6. Apixaban also reduce the production of free radicals and interleukin 6 and interleukin 3. Apixaban and dabigatran also inhibited platelet aggregation. In a study including 93 patients, rivaroxaban increased the concentration of anti-inflammatory thrombomodulin and the trend toward reduction of pro-inflammatory matrix metalloproteinase 9 compared to warfarin. Endothelial injury is part of the Virchow triad of thrombosis. DOACs dampen inflammation. Also, there is vasorelaxation due to increased endothelial nitric oxide synthase. The diagram shows the anti-inflammatory activity of DOACs plus vascular protection through inhibition of the patient of the platelet activation, inhibition of platelet aggregation, vasorelaxation, and the endothelial nitric oxide release. The table showed summary of DOACs versus warfarin, advantages and disadvantages. What about renal clearance of drugs? Drugs have varying degree of renal clearance, 80% for dabigatran, 30% for rivaroxaban, and 25% for apixaban. In advanced CKD and the dialysis dependent patient, respectively, apixaban and rivaroxaban are the most commonly used anti-factor 10 direct oral anticoagulants. This diagram showed the pharmacokinetics of warfarin, apixaban, rivaroxaban, dabigatran, and edoxaban, and also the dialysability of these factors for patients undergoing hemodialysis. DOACs versus warfarin in stage 3 and 4 CKD with atrial fibrillation, a meta-analysis which includes 5 hallmark randomized controlled trials comparing DOACs versus warfarin. They including around 13,000 patients. Patients who received DOACs have reduced the rate of all strokes and systemic embolism compared to warfarin, as shown in the figure. Cardiovascular death, stroke, and systemic embolism and major bleeding and the intracerebral hemorrhage in favor of usage of DOAC versus warfarin. On the other hand, there is slightly more gastrointestinal bleeding in patients receiving DOACs versus warfarin, as shown in the figure. In a study enrolled 269 patients with atrial fibrillation advanced CKD, the safety of apixaban versus warfarin. Apixaban used less major bleeding and clinically relevant non-major bleeding versus the usage of warfarin. In a study including 132 patients in hemodialysis with atrial fibrillation, they are classified into 3 groups. Group usage warfarin with targeting INR 2 to 3 and dose and rivaroxaban 10 milligram daily, and rivaroxaban and vitamin K 2 group. This therapeutic option was prescribed for 18 months. The primary efficacy endpoint was a sum of fatal and non-fatal cardiovascular events, as shown in the diagram. Withdrawal of warfarin and the high dosage of vitamin K2 improve vitamin K status in hemodialysis patient. Severe bleeding complication may be lower with rivaroxaban versus warfarin. Another study including around 25,000 patients comparing patient usage apixaban versus warfarin. Patient treated with apixaban 5 milligram twice daily had a lower risk of stroke and systemic embolism, major bleeding, and death compared to warfarin. But when we reduce the dosage to 2.5 milligram, the risk of bleeding is less. But on the other hand, the stroke or systemic embolism are more than the usage of 5 milligram twice daily. The figure shows the major bleeding event-free survival. There is privilege for the use of apixaban versus warfarin. However, in patients with age more than 80 years and body weight less than 60 kilograms, it's recommended to reduce the dose of apixaban from 5 milligram twice daily to 2.5 milligram twice daily, following recommendation from non-CKD patients. This is a retrospective cohort study, United States Renal Data System, about outcome associated with apixaban use in patients with end-stage kidney disease and atrial fibrillation in the United States. The usage of apixaban 2.5 milligram lowers the rate of major bleeding in comparison to warfarin, and the figure on the right side showing a trend toward less use of warfarin in hemodialysis patients. On the other hand, there is trend to more use of apixaban in this population. Oral anticoagulation for patients with atrial fibrillation long-term dialysis. This study identified 16 eligible observational studies, including around 7,000 patients. WAX patients who received apixaban 5 milligram twice daily had significantly lower risk of mortality than apixaban 2.5 milligram twice daily, as I mentioned before. Rivaroxaban versus apixaban in patients with dialysis. Systemic embolism, ischemic strokes, and major bleeding, there is no marked significant difference between both groups. What about dosage of rivaroxaban? Rivaroxaban 10 milligram daily in hemodialysis patient with no residual function achieved a similar area under the curve as rivaroxaban 20 milligram daily in healthy volunteer. Also, apixaban 2.5 milligram daily in hemodialysis patient resulted in a comparable drug exposure as the standard dose in patient without renal function, while 5 milligram twice daily has associated with subtherapeutic level, thus challenging the official dosing recommendation. In their review, rivaroxaban 10 milligram and apixaban 2.5 milligram twice daily are both appropriate for choice for hemodialysis patient. What about drugs limitations? Fixed drug dosage may lead to decreased drug exposure in obese patient and increased drug exposure in underweight patient based on drug pharmacokinetic changes. The International Society of Thrombosis and Hemostasis conducted an analysis whose results suggest drugs are safe in patients 120 kilogram and the body mass index 40 kilogram per meter square at standard doses and are not recommended in patients over 120 kilogram and the body mass index over than 40 kilogram per square meter. A patient with atrial fibrillation may still have ischemic strokes despite taking drugs, and secondary prevention of this incidence, left atrial appendage closure is processed. In our dialysis population, we can apply dialysis risk score. Dialysis risk score includes the components of CHA2DS2-VASc score, history of stroke, diabetes, and older age that were significantly associated with subsequent stroke and omits the components of hypertension and heart failure that were not. The increased bleeding risk in hemodialysis is accounted for by including history of gastrointestinal bleeding, since this is predictive of subsequent bleeding. And this is proposal of anticoagulation strategy in hemodialysis patients with atrial fibrillations. And we have these scores. Dialysis risk score of 2 or more, we have to anticoagulate your patient. Dialysis risk score less than 2, you have not to anticoagulate your patients. Apixaban 2.5 milligram twice daily, rivaroxaban 10 milligram daily, reduction of heparin during dialysis to lowest the tolerated dose, antiplatelet agent re-evaluation and the indication and the stop, it will show in the next slide. Management of concomitant antiplatelet agents for randomized control study consistently found that substituting a triple strategy of vitamin K antagonist, BY12 inhibitors, and aspirin for a dual strategy of DOACs and BY12 inhibitors after recent acute coronary syndrome or percutaneous coronary intervention for stable coronary artery disease strongly reduces the clinically significant bleeding event without increasing the risk of ischemic stroke myocardial infarctions. Also, monotherapy with rivaroxaban was superior to dual therapy with rivaroxaban and the antiplatelet therapy. And the currently recommended default strategy for antithrombotic treatment in patients with atrial fibrillation and the associated cardiovascular disease is therefore to stop triple treatment with oral anticoagulant, BY12 inhibitors, and aspirin no more than 1 month, and to shift to dual therapy with oral anticoagulant and BY12 inhibitors for another 5 to 11 months, and then after you have to omit the antiplatelet agent and to continue only for 1 oral anticoagulant therapy. There is ongoing randomized control trials on oral anticoagulations as shown in this table in front of you. And in my conclusions, DOACs are gradually replacing vitamin K antagonists in the prevention of thromboembolic events in patients with chronic kidney disease due to better safety profile and comparable efficacy. DOACs are preferred over warfarin in patients with mild to moderate CKD, and might be considered in patients with advanced CKD. Dabigatran, rivaroxaban, edoxaban should be used in a reduced dose. Apixaban may be used in a standard dose. In stage 4, apixaban, rivaroxaban Only one slide.
Okay, 1 minute.
You know one slide. Edoxaban might be used with caution in a reduced dose, whereas dabigatran is contraindicated. European recommendations contraindicate the use of old wax in patients with estimate GFR less than 50 ml per minute or on hemodialysis, whereas United States FDA allows the apixaban use in those cases. The treating physician should be aware of the higher risk of bleeding in chronic kidney disease population, regardless of the choice of anticoagulants, and individualize the therapy according to the patient risk factor, including Haas blood score history for bleeding events and concomitant antiplatelet therapy. At the end, many thanks for your attention.